All right, everybody. It is 11:05, and I wanted to thank everyone for coming to join us at our very first virtual emergency medicine research day. Have a great lineup of presenters, some fantastic projects that we'd like to share with you all. I'm very grateful that everyone is able to join us. So a few kind of housekeeping notes. Thanks very much to all of our presenters for being flexible with the format, and we're happy to give you an opportunity to share your work with us today. We want to thank a few people in particular for helping to make this event happen. First, Jill Vaughn in the Emergency Medicine Research Office, who essentially shepherded and got all of the ducks in a row for making this happen, and Amani Otum, who helped with putting this together as well, and also a thank you to Aaron Peterson at the PLP office for coordinating the Zoom and online presentation and broadcasting of all of this, so that people can join us. I do want to note that unfortunately we weren't able to get official CME accreditation for this event, but people still certainly can submit CME credits under the unaccredited educational events category. So for those using Royal College CME credits, it's still under category 1. And there should be a similar category for those submitting CME credits for the College of Family Physicians. So like I was saying, have a great slate of presenters joining us today. I'd like to start off first with Dr. Patrick McLean from the Emergency Strategic Clinical Network of Alberta, who is going to be presenting to us work describing the provincial spread of Suboxone initiation in emergency departments, a quality improvement initiative. So Dr. McLean, it's over to you.
Okay, so as Andrew said, I'm Patrick McLean. I work with the Emergency Strategic Clinical Network. I am a PhD social scientist rather than a clinician. And so I'll be talking about the spread of Suboxone around the province. So we have a large team, including the Emergency Strategic Clinical Network leadership, supported by clinicians at both University of Alberta and University of Calgary, and AHS Analytics for the statistics I'll present. My disclosure, I am an employee of Alberta Health Services. Alberta Health has paid for this intervention and for the evaluation, but hasn't directed the conduct of the evaluation. So opioid use disorder, of course, is a chronic relapsing illness and requires medical treatment. Opioid agonist treatment is the recommended treatment. And so it is replacing harmful opioids people may be taking with something more manageable, which buprenorphine naloxone is the recommended first-line opioid agonist treatment. So this project started in May of 2018, working with emergency departments, and the goal was to develop, implement, and sustain a provincial program for the initiation of buprenorphine naloxone in EDs. So I'll talk about how the program has spread to EDs and then the statistics we capture within emergency departments. So we look at the number of opioid visits in the departments working in the program, how many patients are started on the medication in those emergency departments, whether the patients continue to fill prescriptions for buprenorphine naloxone when they're discharged. And then on the community side, we did have next day referrals to participate in community clinics that were set up through our project manager, Ken Scott. So we asked the clinics to track just numerically how many referrals did they receive and how many patients arrived. So I'm presenting the period up until December 2019, which is where our analysis goes to, and then more recent analysis is underway. But at that time, at the end of December, there were 84 emergency departments in the province participating in the program. 23 were reporting data to us, and so it'll be those 23 that I'll talk about for the rest of the presentation. That may not seem like a lot, but they cover almost 80% of all the opioid presentations in the province, so we do believe we have good data there. And then 22 participating community clinics and 16 reporting data. That includes the virtual opioid dependency program that helps us serve rural populations. This shows the provincial spread of the program by fiscal quarter, starting in 2018, 2019. So you'll see the bars are how many sites joined the program at each quarter. The colors are the different zones. So we started in Edmonton and then Calgary, and then have engaged the other zones as we've gone forward. And the line is the number of reporting sites that is cumulative. So to give a sense of how the number of sites reporting will match the data that I present. For opioid-related visits, we see those numbers go up. And that's largely because we're adding sites throughout these different periods, although we haven't been adding sites nearly as fast in the last couple of quarters, and the number of sites, or the number of opioid visits, have gone down. The number of starts at the participating sites are shown here. This also goes up as we add sites, drops off a little bit in the most recent quarter, which may be due to the decreased number of opioid visits. But in total, we've had provincially that we can track 1,285 emergency department visits where patients receive this medication. Looking at continuity of care, what we did here is we wanted to know if giving people the medication in the emergency department was making a difference on people continuing to have access to that medication. So we looked at whether the patients who were discharged with the medication were still filling it at 30, 60, 90, and 120 days. So at the top there, the 67% light blue bar, that's people filling the prescription at 30 days. And then the next set of bars below that is the people who had an opioid-related visit, but were discharged without buprenorphine naloxone. So we looked at them as an imperfect kind of control group, recognizing people who don't get the medication in the ED still might get it somewhere else, but far fewer of those patients got the medication somewhere else, or were still filling, or were filling prescriptions at the later time period we looked at. So this tells us, we interpret this to mean that our program is reaching patients who wouldn't otherwise be started on this opioid agonist treatment. In terms of clinic referrals and attendances, we do see those numbers go up over time, down a little bit in the most recent quarter, and possibly due to the reduced starts that we saw earlier. But what we're really interested in, how many of the patients actually get from the ED to the clinic the next day. And so you'll see we've got rates between 36 and 59% of patients getting to their next day appointment in the community. We think that is very good when we look at literature around other programs in this area in other jurisdictions. And finally, just two balancing measures. As we collected data, some of our clinician team members were very interested in the length of stay. And essentially, people who get the medication don't have any longer stays in terms of the median than those who are discharged without the medication. So we think that having this program isn't really a huge draw on emergency department resources. And patient safety events. So there is some concern with this medication that patients could have adverse events. For instance, they could precipitate withdrawal if they take it while there's still another opioid in their system. We haven't seen that out of the 1,285 cases we know of where people were started in the emergency department. We've seen 8 patient safety events. They haven't resulted in severe harm according to the reporting and learning system. And they're the kinds of issues that could arise with any medication. They're the wrong time, wrong dose, or not supplied with when requested. And so that is my presentation of results. And I believe we have time for questions.
Yeah, that's fantastic. Thanks very much, Patrick. I should have said this in my introduction. I'd invite people to submit questions electronically using the Q&A function down on the bottom of the screen. I think maybe I'll start by asking you if there's plans to do any kind of economic analyses with this, or do you think that's a bit premature based on the type of data that you have?
Yeah, we've explored the economic analysis in terms of, so are we saving costs to the hospital system? It wasn't a main outcome. Our goal was always just to get as many people who have opioid use disorder started on the medication as possible. And so it's possibly a little, even if it costs more, it might still be worth doing. And so we've been a bit hesitant about the economic analysis from that perspective. We also don't have mortality data, which would be the really strong data to say these are the number of life years that we've saved, and this is the value of those years.
Oh, that's great. And there's a question from one of the audience members. Do you have data on revisit rates for those getting Suboxone versus no Suboxone, and whether that refers to opioid-related revisit rates or other?
Yeah, and so we did look at that. And so for opioid-related visits, there is no difference in the number of times people visit the ED before and after getting the medication at 30 or 90 days. And when we looked at revisits for any reason, we also saw no difference at 30 days, but we saw a slight increase at 90 days. We don't have an explanation for that. It might be that people are more engaged in the healthcare system generally. But we are interested, as we continue looking at different evaluation periods, whether we continue to see that.
And any other additional questions from the audience? Okay. And so, Patrick, anything else you want to add in terms of a soundbite summary or quick take home for the audience?
Only that the program wouldn't be possible without clinicians participating in it. And we hope that this data helps show that the efforts in EEDs is worthwhile.
That's great. Thanks very much for taking the time to present this to us today. It's great stuff.
Thank you.
All right. So I'd like to invite our next presenter to prepare to share his work with us. Next is Emeka Nwere, who's going to be talking to us about the mean abnormal response rates of laboratory tests ordered in the emergency department, data from a multi-center study.
Okay, good morning, and thank you for the opportunity to present. Can everyone hear me okay? Yeah, okay.
Yeah, hear you.
So again, great. My name again is Emeka, and I'm a third-year medical student here at the University of Calgary. So I'm in the pre-CARMS cohort. Again, so the collaborators on this study were Dr. May, Maggie, Dr. Nogler, and Dr. Lang supervised the work. And I have no disclosures. So the key issues that elicited this study have to do with inappropriate lab testing. The cost of lab tests is quite significant. It's often difficult to determine exactly how much the costs are, but we know they are significant. We know that lab test volumes are increasing at 4 to 6% per year, and the number of tests that are ordered per patient is also increasing. Of course, the question is whether we can be more judicious in ordering our tests and to determine which tests are actually ordered appropriately or inappropriately, and whether it is possible to actually establish benchmarks for measurement of inappropriate lab test ordering. This is something that's been attempted at different times in the past. It's very difficult to come to a consensus to find an approach that scales readily across multiple centers and is able to identify factors that may actually associate with inappropriate lab test ordering for interventional measures. So one approach has been proposed by a group out of Calgary, including Dr. Nogler, that involves something called the mean abnormal result rate. And this is a very simple calculation. It's basically the proportion of total tests reported that return abnormal results. And the question is whether this can be used as a sort of a large-scale measure to estimate the appropriateness of the tests as they are ordered. Presumably, a larger proportion of abnormal results will suggest that the tests are being ordered more appropriately. So the objectives of this study were to determine the MAR scores for the adult EDs in Calgary between 2014 and 2018. And the goal of this was to use this as a benchmark and to assess any differences that may exist between the EDs. The goal is also, one of the objectives is also to identify tests with the highest and lowest MAR scores and to assess factors that might correlate with higher or lower MAR scores. So these are the tests that were selected for the analysis. The criteria primarily that they be not specific to a particular population. The notable exception here is overdose iron, and that the reference ranges be stable across the study period. So the data, I'll sort of take some time to describe what went on here. So the data were obtained from Calgary Lab Services, now Blood Precision Labs. Basically sent a list of 33.8 million results. A lot of these just included secondary descriptive results, such as neutrophil percentage, so they were removed. And then multi-component tests, such as CBC, were consolidated. So in the case of something like a CBC, any abnormal result for any component is considered an abnormal result for the test. And given that many of the components may not be significant for the purpose of patient management, this is something that should be taken with a grain of salt, but that's how this was done for the purpose of analysis. That gave us 4 million results. And from here, repeat orders of any test within a single patient visit. And that single patient visit was defined as a 26-hour period spanning, starting from the time the first test was ordered. So any repeat tests were removed, and this gave us 3.4 million results. And of these, 70% of the tests, the test results were ordered by physicians, either ED docs or others, and 30% represented nurse-initiated orders. So the results, the cumulative uni-MAR scores for all 4 EDs was relatively stable, so hovered around 40% across the 5-year time span. We also asked whether there were any differences between the EDs. So we calculated 5-year MAR scores at each ED, and we saw that they were about the same. So there were variances across the board, ranging from 41% at the PLC to about 38% at the South Health. And when we split this graph to sort of look at the results on a per year basis, we see that they sort of oscillate about the same mean, suggesting that the differences don't represent, they're not due to any specific massive outliers that may emerge at one point over that 5-year time span. So we also asked which tests had the highest and lowest MAR scores. So the highest scores were seen with BNP and CBC, and again, considering that CBC is incorporating any components that may have an abnormal result, was osmolality, CSF cell count, and ammonia. Whereas the lowest test scores were seen with glucose, sodium, magnesium, lipase, and total bili. We also asked if there were factors that may be associated with higher and lower MAR scores. So we determined, we asked this question about the total number of tests that were present in each order requisition. We calculated the MAR score for each requisition and asked if there were any differences in the MAR scores. We did see a trend that was significant between single MAR score for a single test per requisition, all the way to greater than 10 tests per requisition, and we saw that they were inversely correlated. And finally, we also asked if physician experience may play into this. So we looked at the number of years since licensure, the proxy for experience, for 209 EDs for whom we had data available in this data set. And we basically looked at their MAR scores. So this graph is a little bit complicated because, of course, individual docs would be present multiple times over this. So the statistical measure I applied was more rigorous in trying to determine if there was significance or not. So you see that the R is a bit low, but it is still significant. So the summary from this is about 40% of tests ordered out of EDs in Calgary returned abnormal results, so about a 40% MAR score. MAR scores are stable across time. They do vary moderately from year to year, but they're reasonably stable for a particular ED, and they do vary between EDs. The per test MAR scores range from between 8% for glucose and 81% for BNP. And it does seem that ED docs get better with age because there's a positive correlation between number of years of experience, or number of years since licensure, and overall MAR score. And that's it. Thank you.
Any questions from the audience members for Rameka? So Dr. Lang is asking if there's literature to suggest that sharing a statistic like this could be used to drive practice change.
That's a good question. This is the first study that's actually applied the MAR score in the context of the ED. There have been a couple of other studies that applied it to family practice in Calgary, and I'm not sure about the extent to which they have been used to improve ordering practices, but certainly I can foresee that where you have hard data of this sort, that reasonably well correlate with actual the quality and the appropriateness or the lack thereof of ordering practices, and that's again something that is open to debate. That there may be value in actually improving ordering practices when people have data like this at their disposal.
Great. And any sense of how these results compare with other groups of physicians?
Yes, so the MAR scores that we have here, so the average about 40% is quite a bit higher than what is seen among family physicians, which I think is sort of around 7 to 8%. And the reason is most likely that we're looking at different patient populations. Of course, patients that are presenting to the ED are going to have a significantly greater acuity than those who will present to family docs. So it is part of the reason why I suggested that this is better used as a benchmark. Now, the way the reference ranges are designed, we would expect that about 5%, that there'd always be a 5% MAR, suggesting that about 5% of results would be returned abnormal, and they would be false positives in the context of a healthy population. But this, of course, would not necessarily be a healthy population they're presenting to the ED. So that is really the only comparison that we have available to us between the ED from this study and family docs.
Okay. Great. And then two people asking the same questions. So I think we'll wrap up with this one. Were the tests that were included based on a nurse-initiated protocol? So did it include any tests that were ordered by a nurse before the emergency physician saw the patient, or were they only tests ordered by physicians?
They were both, and so I sort of removed the extra data in interest of time, but I was able to sort of calculate some of these data. So for instance, highest and lowest MAR scores for nurse-initiated orders as compared to physician-initiated orders. And a quick summary is very surprising, actually. The aggregate MAR score for nurse-initiated orders was higher than that for the physician-initiated orders. So it was 44% versus about 38%. And the reason for that may have to do with the difference in actual type of ordering that was being done. So for the nurse-initiated orders, they were predominantly CBC and differential, that represented about 75% of the tests that were ordered, as compared to for the physicians where it was quite a bit broader. And because the way this study was designed, the CBCs had a relatively high MAR score, it probably shifted the balance in favor of the nurse-initiated orders.
Okay, great. Fantastic presentation. Thanks again for joining us today, Mika.
Okay, thank you.
All right. Next up, we have Dr. Ken Chan, who's going to be presenting on POCUS versus chest radiography for diagnosing pneumothorax in the emergency department. Take it away, Ken.
Hi, everyone. So my name is Ken Chan, one of the PGY 5s. Can I just confirm, Aaron, that you can see my slides and hear me okay?
Yeah, everything looks good and you sound clear.
Perfect, thanks. As mentioned, my study is on the diagnostic tools for looking at traumatic pneumothorax, comparing chest ultrasound versus supine chest x-ray. And we did do a Cochrane systematic review and meta-analysis with this. I am a resident physician and an ICU outreach physician that's paid by AHS, but otherwise I don't have any financial disclosures. So traumatic pneumothorax is a pretty common complication of chest trauma where air gets trapped in between your chest wall and the lung parenchyma. And the typical sort of standard practice that we do in the trauma bay is to get a supine chest x-ray while the patient is lying supine. And, but previous studies have shown that chest x-rays are poor in terms of picking up pneumothoraces. Not only that, it also takes additional time, additional equipment, as well as personnel. And there's also a small dose of radiation exposure to the patient and also to the healthcare providers, hence why this gentleman in the back of the x-ray machine there is wearing some lead protection. It's also pretty hard to pick up some of these pneumothoraces when you're looking at it real quick and you have to really interrogate that x-ray to look for that pneumothorax. It's pretty subtle. The gold standard for detecting traumatic pneumothoraces is to do a CT scan, but that involves moving the patient out of the trauma bay and into the CT suite, which, as you can see, is fairly bare bones in terms of resuscitative equipment. So if the patient were to deteriorate, for instance, we would be in a lot of trouble. Not only that, it takes more time, more personnel to move the patient out of the department there, and also it exposes the patient to more radiation. So we propose using chest ultrasound, which is readily available at the bedside already when we do our fast scans for intra-abdominal injuries. It's portable, it's easy to perform, and it takes essentially really seconds to minutes to perform this on both sides of the chest. So we performed a systematic review and meta-analysis, and our primary objective of the study was to compare the diagnostic accuracies of chest ultrasound versus supine chest x-ray for diagnosing traumatic pneumothorax in the ED department. And then for secondary objectives wise, we were investigating other effects of potential sources of heterogeneity, things such as the type of ultrasound operator, the type of trauma, whether this blunts are penetrating, and also the type of ultrasound probe used. We opted to include only prospective paired comparative accuracy studies, meaning the patient would have to receive all three modalities, such as ultrasound, chest x-ray, and also CT scan. And the traumatic pneumothorax were the only patients that we included, so no other etiologies, and they had to be trauma patients in the emerge, not in the ICU or in the OR or in a bronchoscopy suite. And we included all ages and gender as well too. We also opted to have the ultrasound operators be a frontline non-radiologist physician, i.e. a emergency physician or a trauma surgeon. So we didn't include any ICU intensivists or pulmonologists or anesthetists, just simply based on reflective of trauma care. So after reviewing about 2,300 studies or so, and we pared it down to 25 for full text assessment for eligibility. And then afterwards, we pared it down even further to 13 studies to be included, 9 of which we included in our primary analysis and 4 in our secondary analysis. In our primary analysis, looking at patients with traumatic pneumothorax, you can see in the general sort of gist of things that sensitivity for chest ultrasound is kind of homogeneously quite good in comparison to the heterogeneous population of the chest x-rays there. But specificities were about the same on both modalities. This is the key slide here. It's the summary ROC curve that we used from our meta-analysis. The black dots represent the ultrasound data, and the red is the chest x-ray. The hollow points there represent data from each individual study, and the solid dots represent our summary data. The little dashed dotted line right around that is the 95% confidence interval, and then these dashed lines here is the 95% prediction line. Meaning, if we were to add a new study and to redo the meta-analysis, the data points should fall within that range to be included. As you can see, the summary sensitivity for a chest ultrasound is 0.91, and the specificity is 0.99. Whereas supine chest X-ray sensitivity is about equivalent to flipping a coin at 0.47, and specificity is 1.0. The difference between the two in terms of sensitivity is about 0.44 difference, which is statistically significant, but for specificity is essentially the same. There's no statistical difference. In performing our subgroup analyses, we opted to look at compare the different types of trauma. Unfortunately, there weren't any studies that specifically only looked at penetrating trauma. They had a blended population of patients. But all in all, the general gist is that sensitivity of chest ultrasound is superior to chest X-ray. In terms of type of ultrasound operator, comparing emergency medicine and trauma surgeons, emergency physicians tended to have a little bit higher sensitivity at 0.91 compared to trauma surgeons at 0.82, but specificity was the same. And then finally, looking at the type of ultrasound probe, there really wasn't a difference in between the three different types of modalities that were used. We did opt to do a planned sensitivity analysis just because of the blinding issues. And we wanted to look at only studies that had a lot of, that only were blinded in between chest ultrasound and chest X-ray interpretation. But the general trend is the same in that sensitivity is still higher and statistically significant. The strength of our analysis was that we had a very comprehensive search strategy. And despite the paucity of the comparative diagnostic accuracy studies, we felt that in comparison to previous meta-analyses that were done, this was the highest in level of quality of evidence, just because rather than comparing chest ultrasound to CT versus chest X-ray to CT, we compared it within the same patient population, and there was no sort of comparison between different patient populations and pooling the data together. Obviously, diagnostic ultrasound and X-ray interpretation is fairly operator dependent. And so we did try to do a sensitivity analysis to try and blind the different interpretations in between. A lot of the studies did have issues with poor reporting of their blinding procedures, but we felt that our data does represent essentially a real-world clinical practice, and I think that it is applicable. So in conclusion, diagnostic accuracy for chest ultrasound performed by the frontline non-radiologist physicians for detecting traumatic pneumothorax in the ED is superior to supine chest X-ray, and that's regardless of whether what type of trauma they had, the type of ultrasound operator, and also the ultrasound probe. And we feel that chest ultrasound should be incorporated into our routine management of trauma patients with suspected traumatic pneumothorax. I'd just like to thank my team, Daniel, Andrew McCrae, Yumisi Takwangi, Zara Premji, Eddie Lang, as well as Abel Wakai for helping with this systematic review and meta-analysis. Couldn't have done it without their help. Thank you.
Thanks very much, Ken. We have time for a couple of questions from the audience. So I guess my question is, the ATLS purist would say that there's more than just pneumothoraces on the supine chest X-ray that you may want to know about before going to the CT scanner. Do you think, based on your findings and common sense, that that we're ready to do away with the supine chest X-ray in the primary survey?
I think until we have enough evidence for ultrasound looking at the other modalities, not quite yet. There have been a lot of studies looking at different sort of other trauma pathologies using ultrasound to diagnose it, such as lung contusions, pleural effusions, rib fractures, and even findings of like ARDS, pulmonary edema, and so forth. But until further studies have developed enough robust evidence for that, I think chest X-ray will still be here to stay. Until then, I would stay tuned.
Okay. And one question from the audience: did any of the, or how did the studies describe training for detection of pneumothorax, or did any studies evaluate the training for pneumothorax detection?
Yeah, so a lot of the studies did describe in their methodology, whether it be a dedicated teaching session and practice scanning before they were eligible to be the operators of the ultrasound studies. And then there were some that were just considered as part of like the residency training program, and they were incorporated into that as well too. So the studies, for the most part, did explicitly describe the definition and how they considered a positive scan for pneumothorax, and they definitely did receive some form of training ahead of before they started enrolling patients.
Thanks, Ken. That's a lot of effort you put into that, and thanks for sharing that with us today. We're going to move on to our next presenter, Tori Lau, who's going to be presenting on the effect of sex on ED opioid prescribing in a large multi-center cohort.
So hi, I'm Tori. I'm a family medicine PGY1, and I'm presenting on sex-related differences in opioid administration in the emergency department. The study was supported by Dr. Hayward and Dr. Innes. I have no disclosures, no conflicts of interest. So the opioid crisis in Canada is a major healthcare concern, and it's causing a lot of uncertainty in opioid prescribing. Family doctors, emergency medicine doctors are balancing the risks and benefits of prescribing these medications. There's evidence to suggest that pain expression and experience differs by sex, and this may impact opioid prescribing. But the literature is quite inconsistent. Some studies will suggest that women receive more opioids than men, others suggest the opposite, and some suggest that there's no difference between the sexes. Notably, none of these studies looked at administrative data, or many of these studies looked at specific pain types like abdominal pain or musculoskeletal pain. So we conducted a study to try to clarify whether sex bias exists. We designed a multi-center population-based observational cohort study. We used an administrative database from all Calgary's emergency departments over a one-year period. Eligible patients had a presented complaint belonging to one of the 9 pain categories that we defined, and I'll show you that on the next slide. We also included anybody presenting with a triage pain score above 3 that may not necessarily fall into the pain archetypes. We excluded patients presenting with a pregnancy-related chief complaint. And we also excluded patients presenting with a complaint that had a 10% or less opioid administration rate to focus our study on complaints with significant likelihood of opioid exposure. And also complaints with less than 50 patient cases, just to reduce the number of rare complaints presenting. Our primary outcome is the administration of any opioid in the emergency department. And these are our pain archetypes. So we also plan some subgroup analysis within each of these pain archetypes: abdominal pain, chest pain, extremity pain, back pain, headache, flank pain, and so on. We did have some, and expected some missing pain scores. So we used multiple imputation for this. We used a multivariable logistic regression model with the outcome variable being any opioid administered. Adjustment variables included age, pain severity, triage acuity, hospital site, and pain category as well. So in total, we included 119,000 patients. 55% of them were female. In general, comparing males to females, they presented with similar age, pain scores, and triage acuity, but females did present more with severe pain. And then there are some differences in terms of the types of pain that the sexes would present with. In our unadjusted analyses, there was no difference in opioid administration between males and females. And this was consistent with different routes of administration and also the to-go packets that were dispensed at discharge. This is our multivariate regression analysis, and I'll quickly walk you through it because it's a little bit busy. We can see that male sex was an independent predictor of opioid administration with an odds ratio of 1.05. Naturally, increasing pain score and increasing triage acuity would predict opioid administration. Interestingly, there was some site variation in the provision of opioids. The Peter Lougheed and the South Health campus were actually protective of opioid administration, whereas the Rocky View was predictive of opioid administration. This is compared to Foothills as the reference. doesn't necessarily mean that the hospital site is better or worse, just that a difference existed. The strongest association was actually with pain type. We see that back pain and flank pain was the most predictive of opioid administration with an odds ratio above 7. And then abdominal pain and trauma pain were also quite highly predictive. This is interesting because in many guidelines and recommendations from societies such as Choosing Wisely, back pain is recommended to not administer opioids for this condition. We also performed a subgroup analysis, and this is relative to male sex. So we can see that the effect of male sex is driven by severe pain, abdominal pain, headache, flank pain, and trauma. Of note, there was not a single subgroup here where females presented or had a higher odds of receiving opioids. So our study's greatest strength is that we included a population-based cohort, and we included a broad spectrum of pain categories. Our study population is reflective of the practice of all the emergency physicians in our city, and therefore we believe our study is quite generalizable. We do have a number of limitations. We elected to use chief complaints to categorize pain patients as opposed to diagnosis. When we looked at our diagnosis data, we had about 4,000 distinct diagnoses, which are very difficult to categorize. So we opted to use chief complaints using the CDIS criteria, which would be reproducible and standardized. Unfortunately, due to the limitation of our database, we couldn't analyze the effect of gender identity, only sex. And we did use multiple imputation for our missing pain scores. In most of our population, our missing pain score rate was about 12%, but there are two categories of pain scores, chest pain and trauma, which had high levels of missing pain scores. And so we did use imputation for this. In conclusion, males were clearly more likely to receive opioids across multiple pain categories, and this is concerning for a sex bias and possibly an inadequate pain management in females. We would like to consider an opioid prescribing guideline, which may mitigate this sex bias and may improve opioid stewardship, such as in back pain. I just have some references here, and I'm happy to take any questions.
That's great. Do we have any questions from the audience? So, question from Dr. Dowling. Did you consider looking at this from an individual provider perspective, i.e. do all physicians prescribe opioids similarly between sexes, or are there differences based on individual physician practices?
Yeah, so our database was not able to provide us with that analysis, but literature does show that there is a significant variability in opioid prescribing. One study suggested there was a 6-fold variation across physicians, and this depends on a number of factors such as physician training, even the school that the physician trained in, the experience and their level of training as well. So unfortunately, we weren't able to provide that analysis, but certainly would be something of interest to further pursue.
Great. So one conclusion could be that females aren't getting prescribed opioids enough, but could it be the opposite, that males are getting prescribed too much?
Certainly. Certainly there is a concern of possibly illegal analgesia in females, and that has been cited in the literature in the past. But of course, there is evidence to suggest that men may be more stoic, and although stoicness can be a suggestion that they won't be prescribed more opioids, some prescribers may be inherently aware of this, such as male physicians, and they may actually paradoxically prescribe more. This was shown in some studies as well, showing that male physicians and male patients, that matching of sexes actually increases the likelihood of prescribing opioids. Other possibilities, certainly patients, male men are more likely to present with trauma, and there's also some notion that they are more likely to engage in drug-seeking behavior if they have substance use disorders, which may also drive the opioid use rate.
That's great. Or is there a possibility that females would be more susceptible to side effect profile of opioids and more likely to decline if offered?
Yeah, for sure. Again, there's evidence just that opioids or women do experience greater nausea and emesis with giving opioids. So there may be some effect of females refusing opioids, or perhaps physicians knowing this increased adverse effect risk and offering different types of analgesics instead.
Okay. Fantastic. Thanks for taking the time to share this work with us, and appreciate you being able to join us. We're going to move next to our next presenter, Dr. Miles Hunter, who's going to be presenting work on personality types among emergency medicine physicians.
Thanks everyone for tuning in with me today. My name is Miles Hunter. I'm one of the R3 emergency medicine residents. I have the honor of having Dr. Catherine Patoka as my research supervisor for our project entitled, What's Your Type? Personality Types Among Emergency Medicine Physicians. Go ahead, next slide there, Aaron. I have no financial disclosures to make apart from being an AHS resident physician as well as an ICU outreach physician. One personal disclosure is that I am a blue personality type. You can go ahead and click the next slide there, Aaron. Which will make a lot more sense when this presentation is done. Go ahead at the next slide. So the Calgary Zone Emergency Department is a very large team. We deliver frontline emergency care and the organizational structure to support it. Effective leadership, communication, and collaboration are essential to our ability to achieve this mission. As emergency docs, whether it be running 2 physician resuscitations, consulting other services, or handover, we are constantly in link with one another. Go ahead to the next slide. However, critically ill patients in high volumes, in an unpredictable and fast-paced environment, have the potential to strain interpersonal skills, communication, decision-making, and patient safety. Next slide. Personality profile assessment tools have been used in the corporate world to successfully enhance self-awareness, promote effective relationships at work, improve communication, and decrease conflict. Although these outcomes seem potentially valuable to fast-paced, time-sensitive emerge environments, they have not been applied extensively within this context. Next slide. As such, our objective was to explore if Insights Discovery, a registered personality assessment tool, could be used to understand the characteristics of emergency physicians within our emergency department. The research question for this initial pilot study was to examine the diversity of personality profiles among a cohort of Calgary Zone emergency physicians and determine if trends exist. So what exactly is Insights Discovery? Next slide. Insights Discovery Questionnaire is a commercial personality assessment tool with validity evidence that provides 4 possible personality colors: cool blue, fiery red, sunshine yellow, and earth green, one of which is identified as the primary personality color for each participant. This tool was selected as it's already licensed for use within AHS and debriefs each participant on the meaning of their profile to promote valuable self-awareness and growth for participants. In short, blue are the calm, methodical, and the calculating. Red are the strong-willed, decisive, and results-oriented. Yellow are the open, intuitive, and visionary. Green are the inclusive collaborators and relationship builders. I'm sure that each of you can picture someone in your mind who fits each of these molds. Go ahead to next slide. A cross-sectional survey was conducted via online administration of the Insights Discovery Questionnaire to 30 staff physicians of the Calgary Zone Emergency Department. The primary outcome was the proportion of each primary personality color among emergency physicians. Secondary outcomes included subgroup distribution of colors for male versus female physicians, as well as age above and below the median. The null hypothesis for our study was that there would be an equal 25% distribution of each of the 4 primary personality types. Next slide. So here are the results for the primary outcome. As you can see, the majority of the participants were sunshine yellow, followed by cool blue and earth green, though these 3 subgroups are not statistically disproportionate from the null. The only statistically disproportionate group was a minority of fiery red, accounting for only 7% of the 30 participants. Next slide. When we explore secondary outcomes, comparing male versus female participants, it should be noted there were 20 male and only 10 female participants, and we see no statistically significant differences between the groups. We do see, however, a statistically disproportionate amount of fiery red in the male group, accounting for only 5% of the male physicians. Next slide. Comparing our other secondary outcome, no significant differences exist between the groups of age below the median of 10 years as staff compared to above the median of 10 years as staff. Interestingly though, once again, there is a statistically disproportionate amount of fiery red, none in fact, in the above mean 10 years as staff group. Next slide. So overall, this study yielded some interesting and thought-provoking results. It's important to note, however, that this is a pilot study with a very small sample size and a voluntary response sampling, which is certainly at high risk of multiple types of bias. Within the results, we found a disproportionately low number of fiery red among the entire cohort. Within the subgroup analysis, male physicians and greater than 10-year staff also had a disproportionately low number of fiery red, but there was no differences between subgroups. Next slide. Future directions include a greater population sample, which includes resident physicians. And overall, our goal is to better understand the mosaic of personalities in emergency medicine, foster self-awareness, and spark team dynamic initiatives. Next slide. Thanks very much for your attention and for listening to my research project. Happy to take any questions.
Great. Thanks very much, Miles. So, question around the differences in personality types in the less than 10 and greater than 10 years of practice. Is there enough data to suggest that the personality types changed over 10 years of practice, like within the individual, or is it that personality changes are associated with greater than, or personality types might be associated with greater longevity in emergency medicine?
Yeah, excuse me, it's a great question. Insights Discovery has shown that there is quite a high reliability when you take the same test twice in short succession. So the reliability of the test is quite high. But interestingly, you aren't static with your results. The same person who took a test today might have a different primary personality color years down the road. And so it's hard to know exactly when you compare the two if it's a shift over time to favor certain personality types, if people lose certain traits with years, or if those staff who have certain personality traits are then protected for longevity through their career. I don't think we can make a comment one way or the other on this study to know that definitively.
Okay. Another question, and I hope I'm going to do justice to Aaron's question, is are personality types equally distributed across the population, sort of in the background, or are the population type distribution that you saw, is that an emergency medicine thing, or is that representative of the population? And Aaron, correct me if I garbled your question too badly.
Yeah, no, I pulled up Aaron's question in the chat there as well and tried to interpret. I think you gave it good justice. So when you compare to the general population, what's difficult is that each study that publishes its results on personality testing has its own inherent biases in the sample that it's testing. Rarely are they choosing the general population. And so I don't know if there's any true studies that give a full representation of what our population has for various personalities. Certainly within certain jobs and within certain industries, trends do exist, but I've yet to find a study of Myers-Briggs or of Insights that actually gives a true representation of society and what the distribution is. And so this study was mainly just to explore within emergency medicine what we might look like compared to an assumed null of 25% for each equal distribution.
Great. And one last question. Do you think people were more reluctant to self-identify with attributes of the fiery red personalities that might be possibly described as negative, so potentially biasing your findings?
Yeah, I think that's certainly a possibility. The participants in our study knew that they were taking a personality test that then would be included for publication. And so certainly with that inherent knowledge, it might have influenced the way that people answer some of the questions. I don't know if there's a way to truly measure that, but I certainly agree that sometimes the fiery red personality type can imply abrasiveness, which it's not truly meant to, but I can understand why that might have biased some of the participants.
Fantastic. Thanks for sharing this with us, Miles. We're going to move on to our next presenter, Mr. Dan Major, who's going to be talking about adverse events in boarded psychiatric inpatients in our Calgary zone emergency departments.
All right, hello everyone, welcome. This is exploring adverse events in boarded psychiatric patients in Calgary zone adult emerge departments. My name is Daniel Major. I'm an undergrad student at Mount Royal University and former peace officer with Alberta Health Services. I've had the pleasure of conducting this study with Stephanie Vandenberg, who's an emerge doc working at a South Health and PLC. I'm also very grateful to have had the support of Catherine and Frank from the Addictions and Mental Health Strategic Clinical Network with Alberta Health Services. So I did receive a summer studentship last summer working on this, and no other mitigating potential biases or commercial support. So I want to start by just explaining what boarding is, and it's the holding of patients in emerge while they're waiting for a bed after an admission decision has been made. And total boarding is the amount of time the patient spends after the admission decision is made until their departure from emerge. For psych-emerge patients, there's a lack of therapeutic resources and environments available in emerge, and treatment initiation may be delayed. Anecdotally, and it varies considerably site to site, but patients will often just be sitting in the equivalent of a cell for hours and not uncommonly days. Boarding also creates a bottleneck for other services such as police and EMS. And according to literature in North America, psych patients, inpatients face higher boarding times than any other service in the hospital. So adverse events are unintended negative outcomes for patients, and for mental health patients in emerge, there's some particular subsets of what this could be, including using mechanical restraints, chemical restraints, sedation, etc. So our purpose was to describe the type, frequency, and significance of adverse events experienced by adult psych patients waiting in the emerge during boarding. We conducted a retrospective chart review for adult patients who presented to one of the 4 emerge departments with admission to an inpatient psych unit over a 4.5-month period. We excluded patients who were admitted to non-psych services first or who were transferred for admission to another site. It is worth noting that because of this exclusion, we are introducing some skewness toward more acute patients at some sites. We rendered a random sample of 200 patients from a pool of 1,258 and conducted a chart review looking for adverse events. We referenced nursing notes, multidisciplinary notes, emerge the physician record of treatment, SCM data, and Perspective, which is the Protective Services Reporting Database. So first we generated a table describing the demographics of our sample population. The average age was 34, the average length of stay was 31.1 hours, and the average boarded time was 23.6 hours. 62% of patients were boarded for more than 4 hours. Using univariate analysis, we determined the emerge length of stay, the boarding time, and the admission type were significantly associated with adverse events while boarding. In addition, the hospital of presentation was significant for adverse events while boarding. And interestingly, we found no associations for adverse events dependent on CTAS, which is the Canadian Triage Acuity Scale, whether the patient was homeless or not, or their method of arrival, for example, police, EMS, or walk-in. So we collected data on 30 different variables we deemed to be directly or indicative of adverse events for patients in PsychEmerge. The 5 most common events were increasing agitation, benzo use, sleep problems, non-security verbal, and security verbal or physical interventions. Summarizing the adverse events by site, we can see that patients who are admitted to that site experience higher adverse events at the Foothills and the PLC. There are many contributing reasons for this, including the types of beds at the site, primary diagnosis, and the population demographics who attend these sites, but the discovery warrants some further investigation. Univariate analysis provided more granularity on the type of admission. So odds ratios showed an 82% higher likelihood of experiencing an adverse event if admitted to a high obs versus a regular bed, and a 92% greater likelihood of experiencing an adverse event if admitted to high obs versus short stay. It is worthwhile to note that there were cases where the admission bed type changed, and we noticed the trend that if patients had to be escalated to a high obs bed, they would wait and emerge. But once they were de-escalated, they would move quicker to a unit. So we believe the layout of PsychEmerge may contribute to the association of adverse events. For example, at South Health, there's a more open concept, and nursing, including PsychEmerge staff, are able to interact with the patients more directly. We also noticed the most frequent adverse event we quantified by far was the use of benzos for sedation or as a restraint. And finally, we wanted to point out that the patients with the highest severity requiring high observation wait the longest and are most likely to experience adverse events. While this could be attributed to the severity of their condition, this may also be attributed in part to the amount of time they are spending in Emerge. Patients in our study had an average boarding time of 23.6 hours. Our high observation patients, however, had an average boarding time of 78 hours. And we can roughly compare this with some caveats to other literature out of the US, which presents a range of boarding times from 2.5 to 34 hours. So some of our limitations was weaker power, and we are dependent on staff reporting every interaction. And we were able to quantify our insight into emerge conditions for PsychEmerge patients. So in summary, we have shown that patients in Calgary were boarded for an average of 23.6 hours in emerge. We have found adverse events to be significantly associated with the specific hospital, length of stay, boarding time, and type of admission, although we have more analysis left to do. Future analysis or future studies should look into the prevalence of adverse events on mental health units and compare to those experienced by PsychEmerge patients. Feasibility and efficacy of service delivery should be explored, alternative models. And further understanding of trends and patterns in PsychEmerge across all sites will improve and raise awareness to conditions faced by patients seeking care for their mental health needs in Emerge. Thank you to Shabnam, our statistician, Vanessa, and Health Records and Protective Services for access to their database. Happy to take questions.
That's great, Dan. I'm sure there's going to be some great operational questions coming from this. And so, yeah, so an interesting comparison would be looking at the same time periods and adverse events on inpatient units. Does this happen as frequently on the inpatient units compared to what happens in the ED? Do you have any sense of that, just anecdotally?
Anecdotally, I mean, we have site to site, usually at least 2 peace officers or security people stationed in PsychEmerge. So just to give you some context, the volume of calls that are expected there. We also work very closely with staff on the inpatient units. So I think an investigation into what kind of medications are being used, the frequency of PRN use, but there's restraints happening on the inpatient units as well, seclusions, moving people from normal beds to high ops. So it would be really interesting to try and quantify any differences in adverse events, especially when a patient is considered stable enough to move on to a unit.
And I guess from an operational perspective, does this suggest the need for either increased or reallocated resources, or do you think you can make that conclusion based on the data that you've collected?
I think it raises interesting questions about resource allocation, especially when we look at, we can look a little bit further out and look at average length of stays. And this, which is about 9.75 hours for the average patient who presents in Calgary, and is 31.1 hours for a psych emerge patient. So I think it raises questions within the larger context of what's happening. On its own, as a standalone, this study alone probably can't answer resource allocation questions, but certainly contributes to a better understanding.
Yeah. Great. Thanks very much for taking the time to share this with us today, Dan. We're going to move on to our next presenter, Matthew Young, who's going to be talking about cannabis-related presentations to urban Alberta EDs after legalization of cannabis.
Excellent. This is our study. I've titled it Clearing the Air. It's a study on cannabis-related presentations to urban Alberta emergency departments following legalization. I have no financial affiliations, but we did receive, I received a summer studentship from AHS, and we received in-kind support from AHS and the U of C. To put some background behind the study, Canada was the first G6 country to nationally legalize the sale of cannabis. Cannabis remains illegal for nationally in the United States, though it is legal in a couple of individual states. Alberta itself also has a high number of cannabis sales, with $195 million based on federal data as of June of last year. And we also have a majority of stores open nationally, with 176 when looking per province. We also have the third highest number of cannabis users, 1 in 5 reporting some form of use, again based on federal data. Our study had 2 objectives. One was to identify changes in volume and provincial call centers related to cannabis-related harms, or CRH, as I'll refer to it. We also wish to identify changes in presentation patterns among those with cannabis-related harms presenting to the ED. We collected data from 3 different sources, from NACRS, HealthLink, and PADIS. We collected data from NACRS from October 1st of 2013 to July 31st of 2019. And then we collected data from HealthLink and PADIS for a shorter period of time because data wasn't available as far back as 2013. We defined urban as Calgary and Edmonton, and we included St. Albert and Sherwood Park given their proximity to Edmonton. These are some of the common ICD codes that we looked for when looking for cannabis-related harms. We did searches to our databases based on ICD codes for cannabis-related poisoning as well as cannabis use disorder. And then we also looked for calls where cannabis was identified as a substance of use or a synonym for cannabis. Our analyses method included an interrupted time series, incident rate ratio, and relative risk ratio. The interrupted time series allowed for us to control both for the population as well as pre-existing trends, because as you'll see in a couple of slides, cannabis is on an increasing trend prior to legalization. We also did a relative risk ratio to determine changes in presentation patterns compared to ED visits for cannabis-related harms pre and post legalization. We also adjusted all of our analyses to the urban population of Alberta in the second quarter of 2019. Our cohort ended up including 14,732 patients. The majority were male, and as you can see from the age distribution, they tended to cluster between 18 and 44, although we did notice a couple of children and seniors presenting as well. Our common presentation diagnoses were quite high in the psychological comorbidities, though we also identified high numbers of unintentional ingestions and some physiological symptoms related to respiratory and cardiac distress. We also noticed it again, the presence of cannabis hyperemesis syndrome, which is common in the literature where patients present with cyclical vomiting. Looking at volume, we did identify a significant increase with a level change of 43.48 visits per month for the entire province, looking at the urban EDs. So that's about a change of about 3 visits per emergency department, which isn't huge. And as you can see as well, cannabis-related visits were on an increasing trend to begin with. Looking at PADIS, we identified an increase of about 4.02 calls per month. And again, we can see that increasing trend over time, pre-legalization as well as post-legalization. Looking at presentation patterns, these are comorbidities that we identified. The blue indicates presentation patterns that have that have decreased, and the red indicates presentation patterns that have increased. Of note here, we can see that individuals who left without being seen have increased, while the number of individuals who are admitted to hospital has decreased. We also noticed generally a decrease in the majority of psychological comorbidities, but an increase in comorbidities like cardiac distress, hyperemesis, and external injury. Again, we also noticed an increase in unintentional ingestions. Looking at common co-ingestants, we identified generally a decrease in co-ingestant use, though for lower sample sizes, we didn't notice any change. Overall, our results indicate that for the province, cannabis legalization is correlated with an increase in the number of cannabis-related harms to the ED and calls to PADIS, as well as an increase in unintentional ingestions and external injuries associated with cannabis. For users, fewer are reporting psychological comorbidities and fewer are reporting co-ingestant use. We do note, however, that more users are presenting with physiological sequelae like cardiac and respiratory distress, and it may be due to unfamiliarity over the effects of cannabis. We also are unsure if the novelty effect of cannabis is driving the current rise in use. And we note that the increase in individuals leaving the ED prior to being seen by a physician might be associated with the effects of cannabis wearing off while they're waiting in the emergency department. Overall, we would conclude that it's unlikely the majority of these injuries are associated with legal cannabis retailers, given that over the period that we collected data, there was a limited number of retailers open and actually selling cannabis. Our core messages are that legalization is correlated with an increase in ED visits and calls to PADIS. We don't yet know if increases are due to the novelty effect of cannabis, and overall, it's a small contributor. I'd like to acknowledge our funders, supporters, as well as my supervisors, Dr. Lang and Dr. Sahaynes. We're open to questions.
Fantastic. Questions for Matthew? I guess if the question is this a novelty effect? How would we try to address that? Whether this is a novelty thing or whether it's something we could expect to see on a continuing basis?
Right. So for us to determine whether or not there is a novelty effect behind the results that we saw, we would have to continue to collect data. We would want to continue to collect data in the upcoming years, particularly since edibles were legalized in October of 2019. So that might also affect the presentations that we're seeing. So we would want to collect data. We would just want to collect more data and to identify whether this trend of increase continues or whether we return back to the levels that we saw pre-legalization.
Great. Any other questions for Matthew? Thanks, Matthew, for taking the time to share this with us. And our next presenter is going to be Rachel Lipp and Catherine Crowder, who are going to be presenting on a multi-center analysis of an emergency physician lead on department flow and the provider experience.
Hi, everyone. Thank you. And I'm just going to share my slides here. Can everybody see my slides okay?
Yeah, looks good.
Great.
Okay, good, thanks. I'll be co-presenting with Rachel Lipp, so I'll present the first portion of this. Our study is called a multi-center analysis of an emergency physician lead on department flow and the provider experience. I'm going to go through a few of the things here. I just can't seem to, there we go. We have no conflicts of interest or declarations. I should mention that I am an emergency physician in the AHS Calgary zone by way of employment. And so although I am a local emergency physician, I have no specific conflicts to declare, and neither does Rachel. By way of background, the emergency physician lead role was conceived of as a role that could help to improve emergency department throughput. There's a number of factors that affect how the emergency department flow and efficiency occurs. Input being all the patients who arrive to the emergency department via ambulance, via transfers, and of course, self-triage or walk-in emergency patients. Throughput is sort of all of the inner workings of the emergency department in terms of how flow is managed, the use of bed spaces, time waiting to be seen, time for diagnostic imaging, reassessment times, consultation times, and eventually emergency discharges or admissions to hospital would make up the output portion of emergency department flow. And all of these things are affected by system factors such as overall volume in the emergency department, number of admitted inpatients waiting in the emergency department, the time of day, the day of the week. Multiple factors will influence emergency department flow. The emergency physician lead is a role that is a staff emergency physician working during the daytime, trying to manage throughput system factors. So trying upfront to initiate diagnostic imaging and early treatment management of patients who have not yet been seen, trying to expedite barriers to care such as use of beds and stretcher spaces in the department, outside consultations that may be taking longer than expected, medical clearance for psychiatric patients, etc. This study looked at that emergency physician lead role at two sites, both the PLC and the Foothills Hospital. It's a mixed methods study, meaning we looked at both quantitative and qualitative data and outcomes. This type of study is a control pre-post intervention study where our control period was 1 year prior to the emergency physician lead intervention, which was staffing of that role, immediately prior, so the 3 months prior to the role, and the post would be our intervention time period where the emergency physician lead was employed first at the Peter Lougheed Center from December 3rd through February 28th, and then at the Foothills Medical Center from March 1st through May 31st of 2019. There's a number of outcomes we looked at, but the primary outcomes and what I will sort of share with you today from a quantitative point of view were the emergency department overall length of stay and EMS park length of stay. We've stratified it by overall as well as admitted and discharged patients. Some of the secondary outcomes that I won't go into here for the sake of time were physician initial assessment time, time to consultations, left without being seen rate, and 72-hour readmission rates at the emergency department. From a qualitative point of view, and Rachel will go into this, we looked at some survey data looking at the provider experience, and I'll allow Rachel to detail that. Overall, our demographics were quite similar for our patients. We did see slightly higher volumes at the Foothills site over all 3 time periods. The admission rate at Foothills, and this is the trend that has been in keeping over time, is slightly higher at the Foothills Hospital. The age of patients was similar, the gender of patients was similar. And because we looked at EMS park length of stay, we of course looked at the amount of traffic received by ambulance to each emergency department. And in general, the Foothills does tend to receive a higher proportion of ground and air ambulance patients. This is just a brief overview of some of our outcomes, and here I've selected to just look at our discharged patients, because presumably we have the most control over emergency department flow in the patients who are seen and discharged from the emergency department, and not as much the patients who are seen and eventually admitted and will potentially have a stay as an emergency inpatient in the department. So Site 1 and Site 2 here refer to PLC and Foothills, respectively. The emergency department length of stay was significantly lower at the PLC with the emergency physician lead intervention. By about 20 minutes, which calculates to over 5,000 emergency department bed hours over a year. So it's quite significant, even though we have reduced this in the order of minutes. That's quite a significant decrease in the emergency department length of stay. However, at the Foothills Hospital, our results were a little bit different. We saw an actual increase in the emergency department mean length of stay for patients, for discharged patients. And we can talk a little bit about a number of the factors that I think may be playing a role in that. And I can touch on that later. From an EMS park length of stay, we saw similar results. At the Peter Lougheed Center, we were able to decrease the average EMS park length of stay by about 20 minutes for patients as compared to both the control and 3 months prior. Similarly, at Foothills, we saw an increase in the in the EMS length of stay for similar reasons, I think related to flow and volume in that particular site. I'm now going to hand over to Rachel Lip to talk a little bit about our qualitative results.
Hi, everybody, just loading the PowerPoint here. Can you see my PowerPoint screen?
Yep.
Okay. So my name is Rachel. I'm going to continue presenting this project by describing the qualitative portion of our data to you today. So we surveyed 256 ED healthcare providers, including registered nurses, emergency physicians, and EMS professionals. Our survey included both Likert scale questions as well as the opportunity to provide written comments. Themes of the survey included impacts of the EPL role on 4 specific outcome measures, including patient throughput, timeliness of admissions and discharges, workload, and resourcefulness to other professionals. Comments were analyzed using qualitative content analysis. So as we discussed the 4 outcome measures, you will notice that there was certainly diversity in opinion regarding the effect of the EPL. Regarding the first outcome measure, optimizing throughput, earlier diagnostic imaging and blood work were frequently described as leading to expedited care of EMS park patients. Many RNs and emergency also commented on the usefulness of the EPL role to facilitate faster coordination of care. However, some participants felt that certain orders were not feasible or that not enough resources, including staff as a resource, were available to complete the workup. Our third outcome measure is the effect of the EPL on workload. Participants commented on the increased workload to nursing staff when working with the EPL. Many nurses identified that the EPL role decreased pressure and stress for triage and charge nurses, but that it could increase the workload for other nurses in the department. Overall, respondents expressed that they would need additional system resources if the EPL role were to be permanently implemented. Our fourth outcome measure was the EPL as a resource to other professionals. EMS professionals believed that the EPL role enhanced communication between EMS and emergency physicians, calling the role invaluable. Emergency physicians commented on the helpfulness of the EPL role in dealing with multiple calls to different consultants, and RNs repeatedly commented on the EPL being an asset and a resource, especially to triage and charge RNs. Several emergency physician respondents expressed concern, however, about the risk of duplication of work and occasionally cognitive anchoring. So I don't have time to give the topic of cognitive anchoring the discussion it deserves, but I wanted to acknowledge that several emergency physicians discussed the risk of this bias in their comments. They felt that the EPL role could potentially increase the risk that ED physicians miss subtle alternative pathology, as these physicians might anchor on the initial thought process of the EPL. In order to reduce the risk of cognitive anchoring, respondents suggested that EPL role clarity would mitigate disjointed patient care and promote consistency between providers, as well as minimize the overlap of patient care between providers. So the unique inclusion of both quantitative and qualitative data in this study provided a robust analysis of the impact of the EPL role on ED flow and provider experiences at 2 ED sites. While site-specific, the quantitative results demonstrated the possibility for significant improvement in patient flow with an EPL role. Through qualitative feedback, ED providers provided valuable insight into the way an EPL can act as a resource and improve coordination of care. Overall, the results suggest that a site-dependent, carefully considered implementation of the EPL role may improve ED metrics and contribute to improved ED provider satisfaction. And I think Catherine and I are both happy to take any questions.
So, questions on the EPL evaluation project from the audience? If you had an unlimited budget to implement this, is there anything that you would do differently?
That's a really good question. And, you know, we had talked a little bit about what it would take to implement the EPL in the emergency department and in such a large zone as in Calgary. I think the nursing feedback was really strong in that the EPL was an additional physician who was able to see patients and initiate treatments and investigations, but that created additional nursing workload burden. And so I think if the EPL was present, I think that considering the staffing for nursing and potentially having dedicated nurses that can work with the EPL to carry out orders and care for the patients that the EPL has seen, that would be a big piece of it. The other piece was the timing of the EPL working. So our EPL was working from 7 a.m. until 9 p.m. on weekdays. And I think it's important to think about potentially expanding the time that the EPL is present in the department, or honing in on the times that it's most efficient for the EPL to be present, i.e. times of highest flow and highest bed block, and potentially even expanding the EPL to weekends, because I think there's a lot of differences in flow and challenges with bed block on weekends. And so that's something to think about with future implementations.
Great. And there's a question that it may have been covered, but were the MDs in the EPL role volunteers, or was this a regularly scheduled shift for all physicians? And do you think the physician selection may have had an impact on the effectiveness of the experience?
Yeah, that's a really good question. The answer is it's a little bit of both. Operationally, this role was rolled out by the zone and supported by medical affairs. And the initial sort of selection criteria for the EPL role was somebody who had worked in the department for at least 5 years, and particularly at that site for at least 5 years, to lend itself to experience with the flow and processes in the department, close relationships with the triage and charge nurses, as well as relationships with the consultants. That was thought to lend itself to better working relationships to improve flow within the department. Now, The shifts were all scheduled. They were scheduled shifts on Medivision. We had a cache of about 40 physicians who shared these shifts. And the benefit of rolling this rollout at the Foothills and the Lougheed sites was that each of those sites often share a staffing cohort. And so many people who work at the Foothills also work at the Peter Lougheed, and so had some experience in the EPL role initially at the Lougheed before working it at the Foothills.
Great. And then just closing with one comment, that it's great to hear the perspective of other healthcare workers as the physician group. There definitely seems to be a focus on the positives. So thanks for addressing both sides of the coin.
Yeah, and we want to share our thanks for everybody who completed the survey. We were overwhelmed with responses, and it was very rich feedback. So if there's anybody attending today who completed the survey, we want to share our thanks. And also thanks to our statistician, Shabna Badenpour, for working with our data.
Fantastic. Thanks for taking the time to present with us today. The final presentation is unfortunately not able to be live with us today, but we're going to be presenting a recorded presentation by Abir Islam, who's going to be talking about evaluation of the impact of the e-scooters on our emergency department volumes last summer.
The Summer of the Electronic Scooter, a multi-center evaluation of the emergency department impact of rentable motorized scooters in Calgary. My name is Abir Islam. I am the medical student working on this project. Other contributors are Katrina Koger, Dr. Stephanie Vandenberg, Dongmei Wang, and Dr. Eddie Lang. I have nothing to disclose for this presentation. To begin with some background information, when Calgary introduced rentable electronic scooters in July of 2019, it was wildly popular, representing the third most popular launch after Tel Aviv and Paris. There has been a significant injury burden attributable to e-scooters in other sites. This study aims to characterize the injury burden seen in all Calgary emergency departments and urgent care centers related to electronic scooters since their 2019 introduction. This study is preliminary in nature, and ongoing study remains pending. For our methods, we retrospectively reviewed all electronic medical records of patients presenting to Calgary emergency departments or urgent care centers with the term scooter identified in the triage note. This data was extracted from the period of July 1st, 2019 to December 4th, 2019. We present demographic information as well as injury types and disposition related to scooter-related visits as well as bicycle-related visits as a comparison as they presented to emergency departments and urgent care centers. We also present a longitudinal presentation of monthly scooter-related and bicycle-related visits for the period of July to November of 2019. A scan of triage notes revealed that out of 671 scooter-related cases, only 65 appear to involve motorized scooters, mobility scooters, push scooters, or scooter-related incidents at a site outside of Calgary. It can be inferred from the scan of these triage notes that a considerable portion of flagged scooter-related presentations are true scooter injuries. Here we present demographic and injury characteristics of 33 e-scooter injuries that were brought in by ambulance. This population of cases is significant because it is associated with a high injury severity. Moving on to results. Overall, in the period studied between July 1st, 2019 to December 4th, 2019, there were 617 scooter-related visits, where 3.1% resulted in an admission. The mean age of these presentations was 29, and 44.1% were female, as can be seen in tables 1 and 2. On the other hand, there were 1,787 bicycle-related visits, considerably higher, with also a higher rate of admission at approximately 8.3% over the same time period, where the mean age was 32 and 28% were female. 31.9% of scooter-related presentations involved patients under the age of 18, whereas this number was 32.6% for bicycle-related injuries. EMS involvement for scooter-related and bicycle-related visits was 12.2% and slightly higher 16.1% for those respective groups. For scooter-related visits specifically, 11.8% involved head injuries, 30.1% involved upper extremity injuries, and 22.7% involved lower extremity injuries, as summarized in Table 2. The respective values for bicycle-related visits were 7.6% for head injuries, 30.8% for upper extremity injuries, and 13.2% for lower extremity injuries, respectively. Furthermore, between July 8th to October 1st, 2019, we identified 33 definitive EMS-transported electronic scooter cases. The mean age was 35 years for these cases, where 51.5% were female, and injuries included head injuries, representing 6.1%, upper extremity injuries, which was 12.1% of these cases, and lower extremity injuries at 21.2%. We also, as can be seen by Figure 1, recorded the monthly scooter-related and bicycle-related presentations. Over this period of time, that is, between the months of July 2019 to November 2019, it can be seen that at all of these months, there were always fewer scooter-related visits as compared to bicycle-related visits. So in conclusion, this preliminary study suggests that despite considerable popularity of electronic scooters following their introduction in Calgary, scooter-related presentations occurred overall less frequently and presented with less severity than presentations related to bicycles. There has been quite a bit of media coverage associated with what seems to be an extensive injury burden related to scooters following the introduction of e-scooters in Calgary. However, this data should be seen in light of analogous data comparing it with bicycle-related visits, which helps place scooter-related visits in the appropriate context. Thank you for listening to this presentation. We would like to acknowledge the Department of Emergency Medicine at the University of Calgary for supporting this preliminary study. Thanks.
All right. Well, that is a wrap for our virtual research day 2020. Thanks very much to all the presenters for taking the time to share their work with us today, and thanks to everybody who joined us to give them the recognition that their work deserves. Some great questions there, some great discussion. Looking forward to doing this again in 2021, hopefully in person, and stay tuned on a date for the 2021 Research Day. Thanks again to Jill Vaughn in the research office, and Amani from the Department of Emergency Medicine, and to Aaron at the PLP program. A reminder that you can submit for Category 1 CME credits with the Royal College and also with the College of Family Physicians. And appreciate everybody taking the time to be with us today. Thanks again, and enjoy the rest of your Thursday.